Thank you, Rana, and it's exciting to be able to go through this guidelines review with you, and welcome to it. And we're excited to just go through with you some of the aspects of this document in terms of what's in it. I'm going to just first give you my disclosures, the research grant support I have from industry, and then the learning objectives of this webinar, which will basically we'll go through some of the highlights of the guidelines paper and some examples that hopefully emphasize how much we think contrast can help you in your laboratory, just for the routine things you do every day, like regional wall motion analysis and getting better Doppler signals. We also want to make sure that we kind of go through a little bit of the ultrasound instrumentation for injection of the contrast agents, a little bit of microbubble physics, not too much, but a little bit, and then the indications for contrast use and the appropriate justification for that we believe exists for sonographer-initiated intravenous access for contrast administration and also starting the IV, and then some policies that we think should be in place for contrast infusion based on revised FDA guidelines. And finally, just to discuss, we'll discuss some new initiatives for contrast as it becomes more and more a part of our routine use in the echocardiography laboratory. First of all, I want to acknowledge all the members of the writing committee. This was a combined effort of hard work. Dr. Mulvey, as you know, was the first author of the 2008 consensus statement. Dr. Abdelmonaim, also at Mayo Clinic, helped out significantly with this document. Kevin Way at Oregon and Todd Belchek also very helpful in getting a lot of these images and in the writing of the document. Charlene Porcelli from South Carolina and Marty McCulloch from Texas, who at the time the document was with Baylor. And Joan Olson, who works with us here, our lead sonographer at University of Nebraska Medical Center, and Dr. Gianni Susui from San Paulo also contributed significantly in providing a lot of input on the writing of the document and the images that you see in the movies as you go through this document on the American Society of Echo website. Again, I want to thank all of them very much for their dedicated effort here in writing this guidelines paper. Just a few comments about the physics and instrumentation. There's some very nice figures which detail some of the newer aspects of very low mechanical index nonlinear activity. One of the things we emphasize, though, as you're a lab just beginning to use contrast, that you learn just how to use it with the low MI, low mechanical index harmonic imaging, which we have defined in the document as less than 0.3 mechanical index. And the tables in the document go through with some optimization features. Table 2, both artifacts and optimization for both the low mechanical index harmonic imaging, which is universal. All the systems have that. And then the very low mechanical index nonlinear activity, which we would like you all eventually to be using, and which is now available on all the systems at a mechanical index of less than 0.2, but gives you even enhanced contrast activity, more bang for your buck, if you will, in terms of what you get with all the commercially available agents. And the reason that is because we know at a very low mechanical index, and we're talking about 0.1 to 0.15, the microbubbles that are available to us today already exhibit what we call nonlinear behavior. That's because they have this high molecular weight gas inside of them that doesn't compress as well as it very well, and so when it's hit by ultrasound, even at these very low mechanical indexes, it decreases in size a little bit, but expands to a much greater degree. And that's because obviously their density changes as you compress them. And what happens is you get what we call nonlinear activity. Some of that being exhibited here, where you see these different harmonic frequencies the bubbles will elicit when hit with this very low mechanical index. Well, tissue tends to have very little nonlinear activity at these mechanical indices. So these very low mechanical index packages that are available to you take advantage of that in that they capture this nonlinear fundamental and harmonic activity from the microbubbles. And, there's very little activity from the tissue. They've developed some very unique methods of canceling that tissue activity. The very first of these was pulse inversion technology, which sent in pulses of alternating phase at a very low mechanical index, less than 0.2. And since they were alternating phase, if you just responded linearly to these pulses, you'd cancel this combined pulse technique because this is the negative where this is positive. So anything that responds linearly cancels, while microbubbles, which already have the low mechanical index, respond non-linearly, exhibit this type of activity you can see here that I'm with my pointer that results in activity when these two pulses come back to the transducer. So nothing from tissue, lots of activity from the microbubbles. So you have this beautiful combination of tissue cancellation and enhanced response from the microbubbles. Other industries have come up with other techniques to take advantage of this nonlinear activity. This is another kind of interesting one called power modulation, where instead of just alternating phases here, you send in the same pulse alternating amplitudes. These very low amplitudes cause just linear activity, but when you go up to a little bit higher amplitude, let's say 0.16 instead of 0.08, you get nonlinear activity from microbubbles. So that you send two little pulses, one big pulse that's twice the size of the little pulse. If you just respond linearly, it all cancels out like tissue would, while the microbubbles have, because of this little bit higher impulse here, some nonlinear activity that can be picked up by the transducer. And so that's another novel way. It's called amplitude modulation of eliciting this nonlinear activity from the microbubbles and simultaneously canceling any tissue signal. And this is the third one that we outlined in the guidelines paper, contrast pulse sequencing, where both alternating phase and amplitude are introduced into the patient with an ultrasound, very low mechanical index scheme. And this seems to bring out even more decibel activity from the microbubbles while still being cancelable by the tissue. And you get very exquisite images like this, where there's bolus injection or a slow bolus injection or infusion of contrast. As it just appears here in the right ventricle, you can see that with this contrast pulse sequencing technique here, there's nothing coming from the tissue. You don't even see this. You can just barely make out that this is a four-chamber view. Then the contrast arrives in the left ventricle here, and you can see very nice contrast activity. Again, very little activity from the microbubble. And because these are very low mechanical index techniques that don't destroy the microbubbles, we see very nice myocardial contrast enhancement in the next phase of this bolus injection again, without any tissue signal. So the degree of enhancement here reflects the myocardial blood volume. And so you see the whole gamut of what these very low mechanical index imaging techniques can do for you in your laboratory day in and day out. We do this about 20 to 25 times a day in our laboratory right now, where we give this infusion of contrast either for a difficult study on the floor or during stress echocardiography, and get the advantage of very exquisite regional wall motion abnormality analysis. And also look at perfusion, though the approved indication, as you know, is just to enhance regional wall motion and be able to delineate areas that you can't see well without contrast. And as you're aware, in 2012, the Inter-Society Accreditation Committee mandated that all systems, ultrasound systems, have instrument settings that enable the optimization of ultrasound contrast agents, just like using the techniques I just described to you. And that can include the low mechanical index harmonic imaging, but we think you're going to get a lot more if you learn how to use the very low mechanical index imaging techniques I just described to you to get exquisite visualization of regional wall motion for the many times we need that during the day. And the mandate also stated that we need to use ultrasound contrast agents for all suboptimal images, and this was defined very nicely in the 2008 consensus statement. If you have two contiguous statements that you can't visualize, that constitutes suboptimal images. But if you're doing a study for regional wall motion or for a quantitative measurement of ejection fraction, then probably you need to visualize all the segments. So it's not that you just have to constrain yourself to this two contiguous segments model. If you can't see one segment and you're needing to do a quantitative ejection fraction, then maybe you should consider contrast in that setting as well, depending on what the indication is. As you're aware, one of the biggest roadblocks to contrast use since its inception has been intravenous access. And the American Society of Echocardiography has strongly supported training sonographers in this area so that they don't have to spend their time doing a study trying to go find a nurse or find someone who can start an IV and give contrast. And the 2001 document, and we reinforced it again now in the 2014 document, that IV training and contrast administration should be done by sonographers, and we want to support you out there that are listening to if you're having trouble with that. If you go to the appendix of the guidelines paper, you see some very detailed instructions on how the process of ordering and personnel are done at the different hospitals that were involved in the writing of the document. Marty McCulloch has been a real champion in getting this working in Houston. And again, as you can see in that document, she's worked it out through her hospital administration that a sonographer or an RN or a nurse practitioner or a fellow or attending can all be involved with this IV starting process, as well as with contrast administration. And again, like I said, I think it's really working with your hospital administration to streamline this so that the patient gets quick and effective diagnoses, and the sonographer can be very much involved with that. At University of Oregon, if you look at the appendix, they also have their protocol for best practices of contrast administration. And again, as you see right up front there, when it's an IV that needs to be started, the sonographer is right up there at the front. And again, we thank Todd and Kevin for really making this happen there and giving us some examples of how that can work. Similarly, for contrast administration, the sonographer can give a contrast while another one's imaging, or I think in some circumstances they just will, if they can try to maintain an infusion with some type of syringe pump devices, one sonographer probably is all that's needed for the whole study. So during this webinar, we want to try to keep you stimulated. We know you're probably eating lunch or something, and we don't want you to fall asleep. So we're going to have a few questions here to kind of see how well you're paying attention and keep you involved. First one here, very low MI pulse sequence, MI being mechanical index here, very low mechanical index pulse sequence schemes. A should be used for perfusion imaging only. B can be used to detect subtle wall motion abnormalities. C should be used for tissue harmonic imaging only. I should put that on there. D are available for three-dimensional transesophageal imaging, or E, all of the above. We give you about 30 seconds to answer that question. Okay, well, we're not off to too good of a starter today. Really, the very low mechanical index pulse sequence schemes that we just talked to you about are primarily useful for both perfusion imaging, but that's not the only thing they're useful for. They're also very useful for detecting subtle wall motion abnormalities. And I'll show you examples of that. Tissue harmonic imaging is a term that's been used for just low mechanical index imaging, like less than 0.3 harmonic imaging, and is distinct from these very low mechanical index pulse sequence schemes. None of these, unfortunately, are available yet on three-dimensional transesophageal imaging. We really do need them for that. But currently, the correct answer can be used to detect subtle wall motion abnormalities. Now, one of the things we talked about just prior to this question was overcoming the obstacles to getting a contrast started. Equally important is recognizing when we should be giving contrast, as we told you about the IAC mandate. And if you fail to visualize two contiguous segments, we recommend that you start out using the low mechanical index harmonic schemes that are available in all systems, just turning your mechanical index down to less than 0.3, and then slightly turning your time gain compensations up a little bit in the near field, and getting homogeneous opacification from either a slow bolus injection or a continuous infusion. And there are situations where we feel it's critical, the guidelines committee felt it was critical that you should see all segments. Clearly that would be during stress echocardiography, where you're trying to diagnose ischemia, and you really need excellent regional wall motion visualization. In the emergency room or critical care setting, it's critical that we, again, see regional wall motion to rule out an acute coronary syndrome. And in the critical care setting, to get a true assessment of ejection fraction and regional wall motion. In chemotherapy patients, where a small change in ejection fraction is important, again, contrast echocardiography in multi-center studies has been shown to be very helpful in detecting small changes and having the reproducibility of a magnetic resonance image. And in cases where the apex is difficult to visualize, there are several cases we outlined in the guidelines document, including apical hypertrophic cardiomyopathy or Takotsubo or non-compaction, where contrast is very helpful in making that diagnosis. Now on your screen right now, I'm going to show you a couple of examples where low MI and very low MI imaging has been very helpful just in the setting of stress echo or chest pain evaluation. This was a 73-year-old male with end-stage renal disease that had hypertension and paroxysmal atrial fibrillation that was referred for stress echocardiography. These are the non-contrast images here. And again, the image quality does not look that bad, but the sonographer felt the apex wasn't adequately visualized, or maybe a little foreshortened, and maybe the lateral wall was not very well visualized. And I left that apical four-chamber view on the left. There does appear to be some mild distal septal hypokinesis, but when we went to less than 0.3, about 0.27 mechanical index in a harmonic mode, you can see that with slight increase in the time gain compensation in the near field, we got very nice cavity opacification that you can see with low MI harmonic imaging, and you can see very nicely the apical wall motion abnormality that was not so evident on the non-contrast image delineated there. This is that three-chamber view in that same patient. This is the resting study before the stress echocardiography. And again, where the apex isn't very well visualized here, though maybe you think it is seen fairly well, you can see how significant this wall thickening abnormality was when you got good full opacification here with low mechanical index harmonic imaging. And these arrows depict those locations of the defect that we saw in the apical 4 and 3 chamber views here. Again, and this is a very good way to start if you're not using contrast yet at this point, is just use the less than 0.3 mechanical index harmonic mode that you're usually using just for imaging at a higher mechanical index, and then use just your time gain compensation or your TGC settings to optimize that near field gain, and follow some of the instructions there on Table 2 of the document, and as well as on Contrast Zone on the American Society of Echo website, that will optimize this for you, and you'll begin to see right away how contrast can give you some very detailed visualization of regional wall motion. Now, as I said, we would like you, as you learn more about contrast, to begin eventually using the very low real-time sequences just to improve your detection of regional wall motion analysis. And I'll show you a couple examples of that as well. This is a patient, again, that was being evaluated post-myocardial infarction to get an ejection fraction. And this was the non-contrast image here. Pretty reasonable images, but they said they wanted an exact ejection fraction. They were concerned about whether they needed a defibrillator. As you know, that's very ejection fraction based. And so I wanted to show you just again to outline a couple things you don't really want to do with just when you're using low mechanical index imaging, which is here, and then this is the very low mechanical index imaging technique here. So this is just 2 button pushes here and a contrast, a low bolus of contrast here. And you can see here, when they did the low mechanical index harmonic mode, the mechanical index was still 0.5. So there's a lot of contrast destruction there. And so you're not really getting the real optimization of the contrast here. You would really want to turn this down to less than 0.3 in order to prevent some destruction in the near field. They had already turned the focus, you can see, up to the near field to try to get a slightly better delineation of the contrast. But even with that, you've got to have that mechanical index down a little bit more in order to reduce the contrast destruction. Or if you have this available, and as I said, all systems really do, our manufacturers at least have this available, you can go to the very low mechanical index pulse sequence scheme, in this case, the amplitude modulation mode or power modulation, and you can see how much better the apex fills out here at a mechanical index of 0.1, and you incidentally pick up the apical thrombus that was also present in this patient following myocardial infarction here. Again, demonstrating that you can get much more from the same amount of contrast if you learn this very low mechanical index scheme just to improve your regional wall motion analysis. Now, movie 11 is a very good example on the website from this document. If you go to the website, you can click on that. I'll show you an excerpt from that. This was a patient, a 54-year-old woman with nausea that was, again, associated with some shortness of breath, a non-diagnostic EKG in the emergency room, but there was some kind of less than 0.1 millivolt ST changes, and they wanted an echo to assess for a resting regional wall motion abnormality. The initial troponin was normal, and the sonographer did everything they could to get a good look at the regional wall motion analysis here, using even B mode harmonic color here, and they felt that everything was moving fairly well, but the physician was still concerned and wanted contrast to still better delineate these areas that maybe weren't totally seen. Though eye was certainly looking like if you look at it usually here, you probably say that looked pretty normal. But lo and behold, when we gave, in this case, a contrast infusion here, you can see there was a discrete inferolateral wall motion abnormality right here. You can see that here is that very low mechanical index pulse sequence scheme. A high mechanical index impulse flash was given to kind of clear the myocardial contrast, so that during that replenishment phase, you could see this area right here in the mid-inferolateral segment that wasn't moving very well, clearly not evident on the non-contrast image. This patient had a 100% circumflex occlusion, and their next troponin bumped to 10, okay? But they had to wait 4 hours for that. Because this diagnosis was made right at the bedside, the patient went to an intervention much sooner than when the troponin came back around 9 or 10 o'clock that night. Because the contrast delineated this regional wall motion abnormality in a patient with the typical atypical symptoms that we tend to see sometimes in women. This is where it very much helped in detecting this acute coronary syndrome that actually was a non-ST segment elevation myocardial infarction. Here's another example of a patient that arrived to the emergency room after a VT arrest, was shocked, and they wanted a quick echo to see that EKG did not show any ST changes post cardioversion, but there was some voltage criteria for LVH, so they still wanted an echo to rule out any regional wall motion abnormality. These are the resting apical 2 and 3 chambers here. Again, contrast was given right away because once they got these, they could see they weren't seeing all the region segments very well, and wanted a quick assessment of regional wall motion. Well, contrast can be given real quickly at the bedside. As I said, there's in the appendix, there's several ways to do this. You can dilute Definity in 10 cc's like the Mayo Clinic does, and give that as a 0.5 cc's after you've diluted it half a vial in 10 cc's, and give 0.5 of that with a 3 to 5 milliliter saline flush over 10 minutes, or you can just infuse it like some laboratories do. But in this case, this was a contrast infusion, and the definite basal to mid inferior wall motion abnormality was detected, and the patient did have an acute right coronary occlusion. This is a 3-chamber view in that patient, not as impressive as the 2-chamber view, but again, contrast quickly at the bedside made a diagnosis that really got this patient where they needed to be. Let's go to our second question here. This is a contrast injection. This is a bolus injection, just as like I described to you previously, where slow flush was given. So you're seeing the first part of the contrast appearance here. This is a patient that was referred for a stress echo, had a previous interseptal and apical myocardial infarction, and they were looking for ischemia outside that territory. But as the contrast first appeared in the left ventricle here, and then later, about 2 seconds later, you see contrast here, and then eventually you see this full pacification image here, again with a very low mechanical index pulse sequence scheme. Here's the way it was given. Here's the sequence of time of appearance of contrast in the left ventricle. I would like you to tell me what you think this contrast appearance delineates. I'll go, I think it's on the next one here. There are the choices. Give you about 30 seconds again to answer that one. Very good. Well, the majority have got that one right. This was a very interesting case here of a pseudoaneurysm that was really, I'll go, I think it's on the next slide here. Yes, there's the right answer. Very good, everyone, or 656% of you. You can see that the contrast first appeared here and appeared to delineate the apex right here, but then this was like a slow bolus, so there's kind of progressive opacification, and then you can see there's another little hole right here. I apologize that this it maybe not playing quite at the frame rate that's helpful for that, but you can see there's a little hole here, and then contrast filling another cavity here outside of what we thought was previously the apex here, which is really a scar here, which, as you can see, doesn't opacify at all, but there's a narrow neck hole right here, with contrast going into a pseudoaneurysm, which certainly complicates myocardial infarction, as it did in this patient here. And contrast is very helpful for delineating both the neck, the narrow neck, and the systolic flow into the pseudoaneurysm. Here's another example of a patient that we just had recently where they had a distal, a pulmonic valve prosthesis, and traditionally you think, well, we can see the pulmonic valve pretty easily, but this was a valved conduit. It wasn't just a pulmonic valve prosthesis. This patient had a right ventricular systolic pressure of 70. This is all we were getting for the gradient across the valved conduit. But again, we were concerned because of the poor window quality that maybe we weren't getting good Doppler quality. So we just gave a slow infusion of a contrast agent, and look at this. You can see there was a big gradient across that valved conduit that was not delineated with just simple Doppler examination. That actually turned out to be this is the CT image from that patient that was obtained after the Doppler echocardiogram, demonstrating that there was a stenosis. Right here's the pulmonary artery bifurcation here, and just at the distal part of that valve conduit, there was a discrete stenosis. And for these Doppler or these abnormalities that are in the far field, like this was, and like aortic stenosis is sometimes, contrast enhancement can be very helpful for improving the Doppler signal quality. Now, we want to spend just a couple minutes, like the document did, on the safety aspects. You remember in 2007, the FDA listed a black box warning on the use of contrast agents in several areas that were quite perplexing to everyone, such as patients with in the critical care unit or with pulmonary hypertension. There was concern that this would obviously hamper the use of contrast and potentially the beneficial effects of contrast. Well, as you know, since that black box warning, several multi-center and single-center studies have shown that for both Definity and Optison, as well as for Sonoview in Europe, very safe profile. There's been a series of revisions that the FDA has made since then, most recently with respect to stress echocardiography and pulmonary hypertension, and there's no longer any kind of period of monitoring required after administration of contrast. And current contraindications are listed as right to left shunting. We'll go into that in just a little bit in a second. Hypersensitivity to perflutrin, or in the case of Optison, hypersensitivity to blood products. It is the consensus of our writing group, though, after reviewing all the literature that's been published of hundreds of thousands of cases now of patients receiving contrast, that the life-threatening reactions that the FDA was originally concerned about are extremely rare, perhaps less than 1 in 10,000. But that still requires that we should have resuscitation equipment available for what we call this anaphylactoid type of reaction that can occur. It is important that your lab be able to do that, as most echocardiography labs are. And most importantly, it should not be used as an excuse not to have a policy for contrast use in your hospital because of the overwhelming benefit of contrast use and this risk being extremely low. You certainly have to be prepared for it, but that risk is extremely low. In a setting of pulmonary hypertension, we did review this in the document and reviewed several retrospective and prospective studies. So Figure 4 is given as I'll give you an example of the largest study we could find looking at the right ventricular systolic pressures ranging well above 70 to 80 millimeters of mercury. You remember the case I just presented to you where we used it to enhance Doppler. That patient's right ventricular pressures were 80. And the FDA has removed this as any contraindication to contrast use because of data like this, where over 6,000 patients were looked at and a wide spectrum of different elevations in right ventricular systolic pressure, including those exceeding 60 millimeters of mercury, where you can see those that got contrast versus those that did not get contrast. Both early and late survival were unaffected by the use of contrast. So it is not a contraindication. We don't have as much data yet, maybe on formal data, I should say, on patent foraminal but we have large amounts of data. We know that a patent foraminal, which would technically qualify as a right-to-left shunt. We know that 35% of us are walking around with these, and there have been no problems ever with all the patients receiving contrast, and we assume 35% of them have patent foraminal valleys. So there clearly needs to be some clarification of what is meant by right-to-left shunting. There's been a recent paper from Chuck Herzog's group at Hennepin County in JACC Cardiovascular Imaging that looked just at patients that had documented right-to-left shunts with saline contrast, and all of them did very well with the systemic contrast administration. So the writing group feels that it is certainly safe to use contrast, and that there is really more work obviously needing to be done, but that is certainly safe in patients with patent foraminal valley, as well as patients with even severe pulmonary hypertension. The table 2 in the document, again, gives you some key components for optimizing your exam. I encourage you to please spend some time looking at that. Again, as we said, very low MI pulse sequence schemes like we described at the beginning of this talk are considered optimal. Remember, in that setting, you do maybe have to do a little near-field gain optimization, though some of the manufacturers now are rebuilding that into their more current versions, like the X5, for example. On the Philips, I know, has some of that already built in. But for the most part, analyze your image and make sure that you have homogeneous opacification. You may have to adjust the time gain compensation in the near field slightly, and use the brief high mechanical index impulses if you can to clear the myocardium, not the cavity of contrast, because even if you don't want to look at perfusion, it is exquisitely helpful for analyzing wall thickening during that replenishment phase. And I think, for example, during dobutamine or exercise stress echo, we find that this is very helpful. We get a brief high mechanical index impulse and then analyze the wall thickening as well as that rate of contrast replenishment if you're interested in looking at perfusion, which is obviously off-label, but still we think very helpful. As many both multi-center studies have shown, it correlates very closely with radionuclide perfusion imaging assessments for coronary artery disease, and is very helpful in predicting the outcome of these patients, both during dobutamine and dipyridamole, as well as a treadmill exercise stress echo and bicycle stress echo. So to conclude, it is very important that the writing group felt that we work with sites, other organizations, the International Contrast Ultrasound Society, the Accreditation Committee, the American College and American Heart Association, to assist sites in getting uniform use of contrast, at least throughout the country, if not throughout the world, because the benefits to the patient are currently just being in hospitals where contrast administration policies are in place. And I think probably one of the most telltale examples of that was Mike Main in Kansas City publication at the beginning of this year, looking at hospitals that did use contrast within the first 48 hours versus those that did not use contrast, or patients that did not receive contrast within the first 48 hours, and looked at their hospital mortality in the first 48 hours. And using contrast in the first 48 hours with all kinds of propensity matching scales here, that's what these digits imply here, is trying to match patients as possible, since these were retrospective comparisons. A lot of propensity matching was done to ensure we're looking at the same type of patients and same severity of disease. And you can see, regardless of that, use of contrast in orange was associated with a significantly reduced mortality. There is a benefit, it appears, to getting that diagnosis right early, and contrast can help you as a sonographer and physician in getting there. Let's go to the final question here. Which of the following statements is true regarding ultrasound contrast agent use? A, ultrasound contrast agents should not be used in stage 3 to 4 chronic kidney disease. Ultrasound contrast agents are contraindicated in patients with severe pulmonary hypertension. B, anaphylactoid reactions to ultrasound contrast agents are rare. And D, ultrasound contrast agents should not be used in critically ill patients. I'll give you 30 seconds to answer that. Very good. Excellent. Excellent. A lot better than our first question, so hopefully getting the point across. But it's not surprising that you will hear this happen sometimes, that because we use the word ultrasound contrast, that someone will think they shouldn't get it because they have renal insufficiency or they've had an allergy to iodine. And the writing group took that into consideration, as I'll talk about in a moment, on how we should maybe rebrand this. But as we pointed out, ultrasound contrast agents are safe in chronic kidney disease, they're safe in severe pulmonary hypertension, and if anything, what we're seeing from Mike Main's excellent premier database analysis is that it is helping in critically ill patients in terms of getting that diagnosis sooner. So anaphylactoid reactions, as we said, are rare. They're probably less than 1 in 10,000. But we should definitely have policies in place to be ready for them. So because of that, the writing group felt it was very important that we consider a change in name. This is always hard to do because we're so used to using the word contrast, but really what we're talking about is taking an exam that is already very good from the beginning of echocardiography, from Harvey Feigenbaum's very first images. We knew we had an excellent technique and something that we could take to the patient's bedside. We didn't have to give them any radiation, and we could get exquisite quality images. But as we all know, the image quality at times can be difficult, especially in our society with more obesity, more chronic lung disease, more difficult settings. We're made to walk to, our sonographers are going out to the ICUs constantly, going to the emergency room. Everybody wants an echo these days. We really need to make our study an optimal study if we're going to be able to take care of the patients like I showed you in the emergency room, get that diagnosis early, make it right during the stress echo. We're really talking about ultrasound enhancement here. So we would like to call it an ultrasound enhancing agent and to distinguish it from iodine-based media or agents that people are concerned about with renal insufficiency. Obviously, gadolinium is a concern in renal insufficiency, and the iodinated contrast agents are concerned, but we do not have that problem with ultrasound, and what we're trying to do is keep the high quality in our echocardiograms as we go into these more difficult situations. Perfusion may not be an approved indication, but we do know that these very low mechanical index real-time sequences that I talked to you about at the beginning of the talk should be used to improve left ventricular opacification. As I showed you that case where we picked up the apical thrombus and where we picked up the pseudoaneurysm, those were with the very low real-time sequences. We weren't looking at perfusion. We were just trying to optimize left ventricular opacification, the FDA-approved indication. They do allow one to examine perfusion, and that's helpful information. But I think everyone should make a point of trying to learn to use these sequences just to improve regional wall motion analysis and quantitation of ejection fraction. And this really should be applied to all age groups. We are seeing more and more pediatric cases where the windows are difficult and where they're being referred for either stress echocardiography or post-congenital heart surgery evaluations of quantitative RV and LV function. This is a 13-year-old that had some difficult windows, and we used it because they had some changes to chest pain with exertion. And sure enough, during the post-exercise image here, this is after that high mechanical index impulse where we're analyzing the regional wall motion and, in this case, the perfusion. You can see in the 4-chamber and the 3-chamber view, that although wall thickening and the contrast enhancement in the myocardium looked okay at rest, there was a clear-cut abnormality in perfusion in the anteroseptal and apical segments here post-exercise, and this patient had a left anterior descending fistula that was shunting blood away from this segment during exercise that was subsequently coil embolized, and the patient's symptoms resolved. But again, you can see the very exquisite delay and replenishment here in this anteroseptal and apical segment in this 13-year-old that already had some difficult windows that had previous surgery, and it made it difficult to see this without contrast, but the perfusion defect was very striking. Other areas outside of pediatric imaging, vascular imaging, carotid plaque detection is improved with contrast, and you get the added benefit of looking at plaque neovascularization. Vascular surgeons are using this for endograft evaluation during ultrasound examinations. During transesophageal echo, if you look at movie 10 in the document, you can see that difficult to analyze left atrial appendage cases where there's a lot of spontaneous contrast and you're not sure is that a thrombus or spontaneous contrast. Unfortunately, we don't have the very low mechanical index pulse sequence schemes on the transesophageal echo instrumentation, but we really think it will help. But even if you use a very low mechanical index scheme here, you can see Dr. Mulvey's has a very nice example in there demonstrating left atrial appendage clearly delineated with contrast and helped rule out a possible appendage thrombus. Three-dimensional echo, there's been some studies already using contrast for optimal quantification of ejection fraction and regional wall motion. Unfortunately, again here, the use of the very low mechanical index pulse sequence schemes has not been put on the three-dimensional imaging software yet, and so we're stuck with using a very low mechanical index, if we can, a harmonic image, to try to get these improvements in ejection fraction and regional wall motion. There clearly needs to be more help from industry in this area to get the optimal pulse sequence schemes for the 3D acquisitions. I want to close there and thank you for paying attention so well. If you have any further questions, we're going to take some now, but remember you can always go to contrastzone.com on the American Society of Echo website, where we provide a lot of this information in addition to going to the document as you develop your lab and hopefully optimize contrast for day-to-day use. Thank you. I'm going to start with question 1. Is anyone performing myocardial contrast? From Joseph. Coming in later. Yes, we are performing myocardial contrast echo on a daily basis because we feel that the perfusion information adds additional value during a study in terms of prognosis and detection of coronary artery disease. In answer to question 5, do you need standing orders from physicians, or can you just have them a part of your protocol? Yes, I think that in our laboratory we have standing orders from physicians. I think if you have a hospital administration policy, that should work as well. Number 6 was use of contrast to rule out dissection of the ascending aorta. I think that that's a very interesting application, and I've seen some examples of that that are very vivid. And if you do need that, both during transesophageal echo to rule out an artifact, that would be helpful. Most of the time it's very evident, though. But if you have a question about an artifact, that would be helpful. Number 8 is, does the scope of practice for echo tech allow and support contrast injection by the tech? I think that varies from hospital to hospital, Margie. I would say that in most cases, I think there is a need for that because we are seeing that we need contrast in at least 30 to 35% of our regular echoes, and those are often during busy times of the day. So it depends on the size of your practice, but I think in busy hospitals or hospitals where there's a lot of echoes being performed, as we're seeing more and more of these, as echo becomes more utilized in patient care, that it does support its use within the scope of practice. Question 11 is, are your echo techs injecting Optosound or Definity? If so, where do you find the supporting documents to allow this practice? There is, in our hospital right now, we're just working on getting our echo techs, giving these two different agents, and we use either. Both have been effective in improving left ventricular pacification using the techniques we described. But I would say that other hospitals are probably using even echo techs more frequently than we are right now. 13, when Definity was first being used, we were encouraged to recheck tricuspid regurgitation velocities with Definity to better determine if a patient has pulmonary hypertension. We had a couple of examples where each time the tricuspid regurgitation was checked, the velocity seemed to gradually increase. Has anyone else experienced this phenomenon? This is a good question, because I think you really want to make sure you turn your gain down when giving contrast, because you'll get a very large amount of noise into the image if you don't do that. We typically go below 10% on the contrast gain, and then I think you avoid some of the blooming that you may see, and you'll just see the very crisp signal of the regurgitant jet or stenosis jet. Number 14, do we need to obtain consent forms for all patients before administration if in an outpatient setting? We do not obtain consent for contrast at all. It's an FDA-approved drug. You don't give a consent form for any other FDA-approved drug I presume you're giving. And even if it's an off-label indication, we will use certain drugs. So whether inpatient or outpatient, I don't think a consent form is necessary. I think you just inform the patient of what you're doing. Do I understand that echo contrast could be contraindicated for the detection of an atrial septal defect with right to left shunting? I would say right now, yes, that probably fits into the setting of a contraindication. Number 16, do you have any recommendations for lowering mechanical index? I know that lowering the power will also lower the MI, but are there any other settings that can be changed? I think when you lower the mechanical index, you may need to turn your time gain compensations up a little bit, or your overall gain up a little bit, to get which is in order to produce that homogeneous opacification of the left ventricle. And that varies from patient to patient. When you're using the low mechanical index setting, the settings probably should be less than 0.3, but in a very obese patient, you may need to use a little bit more. In a patient that's thin, you may use a little bit less, but you do have to turn the gain up a little bit to still create some background tissue signal in the left ventricle if you're using low mechanical index imaging. Number 17, contrast echo using agitated saline was originally used first in 1968, I believe, for detection of a right to left shunt. If a very small amount of pharmaceutical contrast is injected for this purpose, with much smaller bubbles than agitated contrast, why is anyone concerned about risk? That is a good question, and I think there's always been a concern that since these are higher molecular weight, longer lasting microbubbles than the saline bubbles, that they may persist longer. But you're right, they're very small and very safe, and I think, again, a lot of the contraindications arise just from what perceptions are, just like there was with pulmonary hypertension, and hopefully we'll get some data on that to show that it is safe. But as of right now, as the previous question was, it is still considered a contraindication with a large amount of right to left shunting, certainly not because of a patent foraminal volley. Is respiratory failure a contraindication for using contrast? No. Number 20, what is the status of SonoView for left ventricular opacification in the United States? It is not iodine-based, and we're hopeful that it will be approved soon. Number 22, is contrast considered safe to use if a patient is hypoxic? Again, hypoxic or pulmonary hypertension are not contraindications to contrast use. Number 23, do you recommend still using the less than 0.2 mechanical index in severely obese patients? Yes, we found that to be just as successful. You get just as much penetration with that very low mechanical index, and even in these obese patients. Now, I will say some very obese patients, we've gone maybe to 0.25, but we haven't had to go that much higher because the contrast still works quite well, and ultrasound penetrates fat pretty well. We've learned that. Is the recommendation of mechanical index less than 0.2 recommended for all different types of ultrasound equipment? In general, yes. Now, I would say I haven't used some of the ones on, for example, GE. I haven't used the pulse inversion modality on there. But I think that less than 0.2 is a good guideline at this point because, again, if you go higher, you begin to create some tissue signals and you want a really good tissue cancellation technique. So you may want to go, if you want to try a little bit higher in a very obese patient, like the last question Christian has, it's certainly not like you're going to lose all that benefit. You'll just start to get a little tissue signal. Number 25, is there any contraindication to the use of contrast in patients on mechanical support, such as left ventricular assist device, Impellas, and not only from a patient's safety perspective, but also with regard to the effect on the device itself? There's been some nice publications on this, especially in left ventricular assist devices, where Mike Main has a nice example that we put in the contrast document showing the pseudoaneurysm in a patient with with an assist device, and the Mayo Clinic group has published data on its safety. We've used it hundreds of times in left ventricular assist devices, and it seems to be very safe and certainly not associated with any device malfunction. Number 26, I'm in pediatrics, pediatric sonographer, and we are wanting to know if contrast is safe for our adult congenital patients with complex congenital heart disease, mustard, Stenning, Fontan. I believe it would be a great benefit due to the image quality of our adult congenital population. Thoughts? I agree totally, though it is not FDA approved yet in children, but most of these kids now are often quote-unquote adults. So Shelby Cuddy, our pediatric cardiologist, has published data on this in just the patients you describe here, Ruby, and has shown that it does provide some very nice perfusion and right and left ventricular wall motion data that was not possible, and Doppler data that was not possible in these patients without contrast. So that was in European Heart Journal a couple of years ago. I refer you to that article, and I would get started using it. Is severe liver disease a contraindication to any of the available contrast agents? No. And number 28, are there any neurologic effects that can possibly happen due to enhancement of bubbles? No. For private practice, is a signed consent form necessary for the use of contrast? No. No longer consent forms are needed? Correct. Number 33, do you think that contrast agents can overestimate pulmonary hypertension? As we talked about previously, you want to turn that gain down to less than 10% to avoid some of that blooming artifact and just get that very nice crisp signal you're looking for. And when we have done that, we have found no overestimation of any Doppler signals. Is there reimbursement codes for using contrast? Yes, there is. This has been a limitation for us due to the cost of the contrast agent. Go to the ASC website, and there should be some help there on the contrast codes that are available for contrast for ultrasound enhancement use. We'll try to use our branding name there. Our hospital requires that patients receiving any new medication gets monitored for 15 to 30 minutes. The FDA has removed that requirement, and you do not need to do that for ultrasound contrast, but you do have to have safety policies in place for that rare anaphylactoid reaction. Please provide more information on the MI flash. I'd love to. It basically is a very good technique. Talk to your local representatives. If you have the very low MI software, pretty much all the manufacturers also have with that something they call flash or a high MI impulse that will allow you to clear the contrast. Even your local assistants or reps should know how to use that if you have that software. It's just enough to clear the myocardium and not the cavity, because as Kevin Way and the group at Oregon has very nicely shown, that flow in capillaries is very low, and that's what you're looking at when you see the myocardial contrast. That it gets cleared with that high mechanical index impulse, which is just 4 or 5 frames at an MI that's still well within FDA approval, somewhere between 1 to 1.3 mechanical index, and that clears that myocardial contrast, and then you can analyze that replenishment and also get that very good regional wall motion analysis. Go to the ASC contrast zone website. If you can't get the information you need there, please send me an email, and we'll try to help you use that, because I find that extremely helpful in a clinical setting. It appears that we've kind of run over a little bit here. I love all these questions, though, and we'll try to get to them via email. Thank you very much.